It is always such an honor to be with you, to have the opportunity to host this conference, to help facilitate the conversations that take place, to help pull together the different silos, not just the silos that exist between the world of policy and the private sector, but also some of those silos which exist within the private sector and some of those silos which exist within the public policy side. Again, my name is DJ Wilson. I'm the host, or one of the hosts of this Song and Dance, and this is now our 6th year facilitating the State of Reform Health Policy Conference here in CTAC. And I will tell you that this room only holds 62 tables. And we have all of them here. In our first year we hosted this, we had 300 people exactly. We have grown a little bit since then. In fact, let's bring up the slides, and I want to walk you through a little bit of our story just to tell you about how far we have come because of the help from you all. And I say that because we think of this very much as an opportunity for community fostering. And by that I mean we are not the content providers at this conference. It is not our job to tell anybody how they ought to run their world or business or government. We think of our job as being the room in which the elephant sits. And we get all of the different blind men and women that touch the elephant and experience the elephant of healthcare in different ways. Our job is to be that room. And we do that through a number of different ways. But we've been doing it, as you know, we started here January 2011. We now have 6 total conferences in 6 different regions. And it's the same model. It turns out when we go to Anchorage or when we go to LA, it doesn't matter. It turns out the left hand and the right hand don't talk very well in healthcare. And even though the topics are different, it turns out again, we find a yearning for opportunity to convene and have conversation regardless of the market we're in. But that has all happened, that growth has happened because this community started supporting us back in 2011 and has continued to support us. So we are growing because of you. It also includes, I should say, we think that people today consume information through very discrete and disparate channels and means. And when people find an information source they trust, and if they find it credible, then they stick with that. But mass media, mass market information exchange is not particularly on the upswing. But we have this conference as one niche information opportunity. We also have our website content, which is one niche information opportunity. We think we now are growing into one of the largest healthcare state level, market level healthcare news sites in the country, mostly because there aren't that many other ones. And the good ones are mostly nationally minded that maybe are in California or the East Coast, but there aren't many. We now have, in addition to the web silo, we have the email silo, so to speak. We also do our small run book publishing from time to time. We'll do another one this year called Dear Governor, about the state of reform or about that healthcare crisis, depending on the topic and the title. We have a job board with a series of participants. And so we build all of these different silos or information channels to meet the consumers, this community's information consumption needs. So if you come to the conference and you like it, great. But if you also want to go to our website, that works too. This stands on the shoulders of a number of folks. The convening panel is first among those in our regard. That is a group of folks who, we have 3 slides here, a group of folks who help us craft our agenda, help us identify almost 90 speakers that we have lined up for you this year. And when we have opportunities, we talk with them. When we have crises, we talk with them. And they become, for us, the foundation upon which most of this happens. I will tell you this story by way of explaining the value or one example of the value to us of the convening panel members' participation. And that is, sadly, yesterday at 2:30, or about 2 o'clock, we learned that Daniel Kraft's wife, who is our keynote speaker today, his wife is 23 weeks pregnant and had to have an emergency surgery last night. And so he is not able to be with us today, but we wish him the best. And I haven't heard back about it this morning, but it's just a terrible personal thing for them to go through. And so we wish them the best of luck there. So I sent out an email to our convening panel yesterday and said, hey, know anybody that wants to talk to 600 folks? And so within about an hour, we got an invitation extended to Bill Gates. We got an invitation extended to Governor Inslee. We got an invitation extended to Jim McDermott. We got an invitation extended to 4 or 5 or 6 different VIPs because of our convening panel, because they made calls and emails on our behalf. So thank you, convening panel members. I really appreciate your participation. We have 4 cohorts of engagement that we have to have in order to make State of Reform work. The first cohort's our convening panel. The second cohort is sponsorship. And the first organization to sponsor us, you've maybe heard me say this before if you've been to these, in 2010 when I asked sponsors, Primera was the first sponsor to say, yes, we will support you at your first 2011 event. And so they have been with us ever since, and we just continue to tip our hat to them for their ongoing engagement and support. Likewise, Regents has been with us for a number of years, and you know, we find tremendous value and sort of personal pride that we have some of the most active competitors in the market both engaged with us at State of Reform. And so Regents and Don and his team are another one of our best partners. And we limit our event sponsor pool to only 3 because we want to make sure that that those folks are recognized as sort of being, again, shoulders upon which we stand. And Providence is the largest provider, not only in this state, but in multiple markets, is one of our best partners. We're in Los Angeles in part, for instance, because of their support and engagement. They've been ongoing and engaged with us here. And I tell you, these are 3 of the biggest names in healthcare, right, in Washington State. And so when we are trying to push the envelope a little bit, and we're trying to say, maybe the emperor's clothes don't fit well. These are institutions that have the most, they are on top of the mountain. They are at the leading edge of healthcare in Washington State. In some ways, a cynic would say they have the most to lose from active engagement and active dialogue and active conversation. None of those groups think that. All of them think that we're all better served by more dialogue and facilitation, and so we're just tremendously proud and honored that they have been committed to us over the years. Our major sponsors are also, our second-tier sponsor. I just want to also say a quick thank you to them. United and Molina, likewise, 2 great plans who help us on the Medicaid side think through public sector work and public engagement. Hall Render is a new firm here in the Northwest, but names attorneys you'll know. They're the largest healthcare law firm in the country. PH Tech works with every CCO in Oregon. They know integration backwards and forwards down there, and they're up here working as well. Pacific Northwest University of Health Sciences, not a lot of folks even know that we have a DO school over in Yakima, but they are fully engaged in the conversation in Olympia and are here to make sure that the world understands that they are training doctors to be more collaborative and cross-silo and cross-jurisdictional in their approach. Group Health, I think they are one of the, I think, crown jewel icons in Washington State healthcare and clearly a national leader in their model. Moss Adams, they do tax and audit, but they also have a very strong healthcare consulting practice that's nationally recognized and very strong on the West Coast. Cope Health Solutions is a new partner that we have come to know. If you know acronyms like DSRIP, which I hope you don't, but I know some of you do. That gets into financial remodeling within Medicaid. COPE understands innovation in Medicaid as well as anybody. Foundation for Healthy Generations is one of formerly known as CHEF, doing a lot of great work, particularly around things like adverse childhood experiences. Humana is a Medicare Advantage plan, or primarily a Medicare Advantage plan in the market here. They're a new sponsor this year. Empire Health Foundation has been with us in Spokane since day one. And with SEIU, these two are together. These are two of the most disruptive forces in healthcare today, perhaps neither of which do many people have a full awareness and appreciation of what they're doing. But if you don't know what these two organizations are up to, I'd really encourage you to get to know them and talk to them. And finally, I mentioned we have 4 cohorts. Those are 2 cohorts. The third are our 90 speakers that are here today. You can't throw a conference without speakers, and if we're not going to do content, you need a lot of friends. So luckily we have a lot of friends. But we also, our fourth cohort is we have to have people show up to the party. And if you throw a party and no one shows up, that ain't much of a party. And I'll tell you, we learned the very hard way. You don't throw a party at 8:15 in downtown Los Angeles on a Friday morning. So in our first LA conference here in November, we got up there, we were all excited, really great engagement. Our first conference, we had about 325 people registered, which, like our first year here with 300, we felt really good about that. Got up there at 8:15, and instead of a room with about, there's probably maybe, 400 people here now, I think there were like 80. And I was up there with the lights on, and I was a little unnerved. But ultimately, everyone came in, it was packed, it was awesome, but we'll be starting later next year in LA. But thank you. 615 registrants is far and away our largest number. One of the things I would ask you to think about is we have held fast to the notion that this event probably should be in SeaTac. And we have done that for a host of reasons, primarily because no one likes Seattle traffic, but also because we want to make sure that people from Olympia, from Spokane who fly in, from Wenatchee who fly in, from Tacoma, that we have an opportunity to just help them out a little bit and not make them come all the way into downtown. However, we're not going to go to the Tacoma Dome, and we are getting a little bit full here. And when at lunch, I would encourage you to, fight for your seat early, because when more people show up, this will become even fuller. But I would ask you to think about whether this makes sense to move this to the convention center in Seattle. You can provide that feedback via our conference feedback survey that will go out. I'll just be transparent, I'm concerned that we'll have some fall off. I don't want to be a Seattle-centric. I don't think you want us to be Seattle-centric, but I think we also want to continue to grow this community and conversation. So I'd welcome your feedback there. Next slide. That's about it. So I do have more logistics to go over with you, but at this point, I'll save that till the end of this breakout session. And I'd just ask our morning panelists to come on up to the stage. As you see up on the screen, we have Dorothy Teeter, the administrator from the Healthcare Authority, Jeff White from Boeing, David Snodgrass from Healthcare Management Administrators, and Alex Rule from Arthur J. Gallagher to talk about how employers and purchasers are starting to demand more from their healthcare spend. So folks, come on up and let's give them a round of applause. Either side, you bet. So thank you all for being here. As some of you know, you in particular, Dorothy, because you were on a panel last year, I think of these very much as dinner party conversations without the wine. Meaning you don't know what I'm going to ask, and you have not asked me for those questions, which I appreciate. But I am really interested in this notion of how employers are trying to move the ball forward and trying to demand more value out of the healthcare spend that they allocate. And Jeff, Boeing has been thinking about this in a lot of different ways for a long time. You've been in the field now for a little while in terms of your strategy. Why don't you just set us a baseline first of what Boeing has been doing related to getting more value from its healthcare dollar and the rationale that underpins that strategy?
Yeah, sure. I think, similar to a lot of employers out there concerned about cost, we have a lot of spend in this area. It's an important strategy for the company to provide great health benefits to our employees. And I think, we traditionally pulled on the demand side levers. How do we get consumers more engaged? We can shift things like plan design. And try to tackle it that way. And I think we just recognized, there's only so much we can do as an organization. We may have some more constraints than some other employers out there, but realized we had to tackle the supply side as well. And so several years back, we kind of dipped our toe into more of the direct relationships with some healthcare systems on some medical home pilots, and those went pretty well. And we wanted to even take a bigger step and kind of go with kind of a population-based management approach and contracting approach, and that kind of led us down the path to an accountable care organization contract that we went live with here in the state of Washington 1/1/15 of last year. And so I think we just recognized we wanted to partner and align incentives with the big healthcare, integrated healthcare systems. And we thought by doing so and by hopefully harnessing some of the investments they're willing to make to fulfill their obligations on this contract, that we'd start pushing in the right direction to, again, align employers, align purchasers with, align them with the healthcare system in general. So
Jeff, I want to ask about what some of the maybe specific elements of that are that you're willing to share, recognizing some of that is proprietary and all that. But tell us about, listening to you talk there, it's the kind of thing that even a small business person or a broker representing small business might say, that they wanted to partner and drive more value. What did that internal conversation look like among Boeing executives that said, actually what this leads us to is a fundamentally different kind of engagement than what we've been talking about in the past?
Yeah, I think, recognizing that, we are a large employer here, we have a lot of leverage, we have a lot of, volume that is, patients going through the system here. We sort of felt obligated to try to do something in this space, and we can talk about how, this can be applicable to smaller organizations, and I think there are some, direct and indirect benefits from this. But, internally, our approach, and we probably over-engineered to some extent, like we do a lot of things, but it's an expensive approach. A lot of lawyers, a lot of actuaries. I think there's a variety of different models, accountable care models out there that are really going after the triple aim, and I think that's kind of where we centered our contract. And I think there's a number of different types of contracts that don't need to be as expensive as ours was to just get out there. But our discussion internally was, we want to invest in this opportunity, and if we do it right, we'll be able to leverage this to other markets. And so we got buy-in from our leadership to do that, and we demonstrated that we could drive a pretty darn good return, both direct financial return, but also some of the softer stuff like member experience and quality, which is really important to our leadership, is feeling like having our employees feel like we continue to take care of them.
Mm-hmm. So not just about dollars and cents, not just about pure care and utilization, but other member experience opportunities as well. Mm-hmm. Any specific narratives or stories that have come out of the first year that you can share that you think are interesting and that people would want to hear about?
Well, I think if we think about the triple aim and how we did against those, it's a little early to tell on the financials. Obviously, there's a lag, and I think our view of the financials is whether we meet our goal or not. I think that's a long-term play here. The systems need time to change the way they deliver care to have the right information systems to help them identify who are their providers that are outliers and how do they go tackle those things. So I think the financials are going to take a little longer to play out, but we're seeing really good trends on quality, the quality markers that we were using, and then the member experience. One barometer is how many complaints do we get, and we got very little, and we had a net increase in our enrollment in our ACO plans this last fall annual enrollment. So I think we saw very few people leaving the plans, and we saw a lot of people entering them. So all that together, and we'll do some kind of formal member experience evaluation. But that taken together, we feel really good about the member experience. We feel really good about the quality. The financials, again, I think it's gonna take some time, but we're very encouraged by the conversations we've been having with the healthcare delivery systems and the investments that they're making in care delivery.
Great. And Dorothy, I think the state of Washington is far and away the largest purchaser of healthcare. And not just Medicaid, but also on the public employee side. I know the state employee population is sometimes not the healthiest population. There's a lot of office sitting, and I sit in an office all day, and I'm not the healthiest population either. How has that purchasing approach evolved during your time at the head of the HCA? And I know you just announced about 10,200 or about 12,000 total in 2 programs, but 10,200 folks have enrolled in your new accountable care program that is launched here January 1. Why don't you sort of bring us up to speed on the same kinds of questions? How are things going, and what are the strategic thoughts that underpin what you're doing now?
So I think the first thing I would say is to echo what Boeing did, which is focus on the triple aim. That is our North Star in terms of how we purchase care. So making sure that whatever we're doing with the dollars that we have not only improve the quality of the care and lower the cost trend because of that, but also work to improve the health of the people that are public employees or the people that we really represent and advocate for when we're purchasing health care. So that's the first thing, and I think we took a long, hard look at how we had been purchasing care at the state, had fantastic partnerships with the people that we did work with, but we felt as if we weren't pushing the envelope in terms of the current market and what we all know in terms of investments in clinical information systems, delivery system investments that are being made, the potential that you could use the same dollars and get better outcomes. And frankly, following along very closely with what Boeing had done, because we truly believe at the Healthcare Authority that we don't want to have a lot of one-off new innovations that if we could possibly align conceptually with the triple aim and with some of the measures of quality and cost, that we're going to help our delivery system partners start to align and get rid of some of the noise that's in the system. So I guess focusing on the signal rather than the noise is really important to us. And so as other employers and as we move forward to really focus on that triple aim, use those dollars in the best way we know, that's kind of been our driver for this. The Medicaid piece of it, along with the public employee benefits, it's the same exact thought process. We've got a close to 80% overlap in our delivery systems for our commercial insured population as well as our Medicaid population. So again, if you're envisioning the world of either health plans or our delivery system partners, you want to make sure that as you move forward, you're paying really close attention to what the potential of these integrated systems are and how we can partner with them to move that along.
I want to ask about that connection specifically between the public employee bit, Dorothy, and the Medicaid piece, and how that has those are 2 different programs within the HCA, but I know that there is some cross-silo thinking that's happening. You want to maybe flesh out how those are connected a little more?
Yeah, I think what we've discovered, and because I'm up here and can give a shout out to the Healthcare Authority team, I'm going to do that right now, because we all work together really hard across our PEB and Medicaid programs to say, it's $10 billion we're spending a year in this state on healthcare. We have to make sure that the programmatic rules, regulations that we do need to comply with aren't getting in the way of doing superstar purchasing strategy that partners with our Superstar delivery system. So even though we've got lots of different compliance regulations for different programs, different populations in a sense, at the end of the day, every single person we purchase for wants to know when they walk into a clinician's office, when they call a clinician's office, when they email, when they're learning about the best way to use their healthcare benefits, it's the same exact questions. And we want to, again, make sure that we're helping move the needle across the state with the 2 million folks that we purchase care for, to make sure that we're doing consistent thinking, because the level of income you have doesn't really necessarily dictate. Actually, I have a hard time thinking, except for the most severely vulnerable folks that we serve, that their needs are the same. They have this, we all get, we're all prone to the colds and flu. We all need immunizations for our kids. We all need to look at chronic diseases. So we've really worked hard to have a coherent value-based purchasing strategy across both of our populations. And that's been hard and new work for us.
So David, on the TPA side, on the third-party administrator side, which is mostly what you do at healthcare management administrators, you work with businesses across the spectrum, some large, like I think Peace Health is a client, and some smaller, more medium-sized. And I should note that that is a hard business, and you might not say that, but I think it's a hard business, and you have been around, I think, since 1986, running TPA businesses, so there aren't many who stick around that long, so congratulations, or my condolences, one of the two. Isn't it hard getting these employers that are not buying $10 billion worth of healthcare to really grapple with this stuff? I mean, what is your experience trying to get HR benefit managers or employers generally to really come on board with this conversation?
Well, it varies depending on who that employer is. And we partner with brokers and consultants like Alex and others in the plans that we administer. Generally, the employers we work with, they're all self-funded and they're all sponsoring their own health plan. So most of them are not in the healthcare business. So that's the first kind of barrier. They're running a business and then they're sponsoring a health plan. So there's a lot of reluctance in a lot of cases to engage that actively. And then there is the reluctance to actually get involved in the employee's health care, through that plan. So the strategies that we see really range from just kind of almost running a plan without any engagement and just taking advantage of what others are doing in the market in terms of like the Boeings and the Healthcare Authority to access provider networks or to, as we go forward in the future, access or accountable care type options. So they're followers more than drivers in the big picture. At the other end of the spectrum, you've got a number of employers who really see the value of active engagement in the health plan that they're sponsoring, looking to encourage healthy behaviors, encourage their employees to actually manage chronic conditions, get the needed care. The more that they can do that, I think the better the experience is for them and their workforce. So it really runs the gamut from those that are very hands-off to some that are more of the kind of early movers who get very active in the programs.
I know you mentioned that brokers are one of your key partners. And I bet if a broker can sell it, you can do it. In 2010, when the ACA passed, there were a lot of folks that, particularly related to exchanges, a lot of folks that said brokers were going to go away, that they'd be under threat because of exchanges, and that we would see, at a minimum, a transformation of that service. How have you seen brokers change and maybe evolve in the post-2010 world from where you sit?
Well, I think the biggest change has been really employers that we deal with who are self-funding their program. They have to have a broker partner who understands what that means to sponsor a health plan. There's virtually none of our customers that are buying direct from us. Every single one of them is through a broker consultant. And the role of that consultant has gone from kind of being a shopper on behalf of the employer to actually helping the employer with strategies for things like engaging in health, population health, looking for opportunities to help the employees become better consumers. And so they're truly moving from the kind of the buyer representative to an advocate, I think, for effective delivery on the health plan side. So that's, I think, the biggest difference. And as the delivery of healthcare and the regulation and compliance issues around healthcare continue to increase, then brokers' roles actually are more important than ever. So there is, at the low end, small employers and individuals, there's a lot of direct purchasing, internet-based or through exchanges, obviously. But the typical employer that we work with, the broker role is more important than ever.
And so, Alex, now at Arthur J. Gallagher, but also in previous brokerage firms where you've been, I've known you as, I consider you somewhat of an innovative and disruptive force amongst the broker community. I know you've done a lot of work trying to align some clinically integrated, heterogeneous players into unique and high-value provider networks. And I know that you think, that the broker community is sometimes not doing enough, that the things that the large employers are doing have to somehow filter down to the smaller and medium-sized firms. If you were in the Boeing executive cabinet listening to that conversation, what kinds of questions would you ask them for lessons learned that can be applied to small and medium players? What do the small and medium employers need to know about what's happening in the rest of this sort of bigger purchase world so that they can apply it?
Well, the first thing I'd say is that they need to recognize that they have some influence. I characterize the commercial reimbursement in the provider community as being the holy grail to the providers. And when I say the commercial reimbursement, I'm really talking about the exchange business and the employer business, whether it be fully insured or self-funded. And that puts employers of any size in somewhat of a catbird seat. And what I find is that most employers, of the size that we're working with, most of our clients are between a couple hundred employees and a couple thousand employees. And we have employer clients on either side of that spectrum, but most of them fit in that wheelhouse. And as David suggests, they're busy running their businesses.
Yeah.
And I was in a meeting yesterday with the VPs of HR of 3 large employers. I say large in our market, about 2,000 employees, with a larger health system in town. And the idea there was to just build the relationships between these VPs of HR and the executive team of this health system, and to help them understand one another's perspectives. And I found the dialogue fascinating, because one of the things that came out of it was that these VPs of HR uniformly said that they haven't really perceived their roles to be ones of encouraging engagement. I asked each of them what
Encouraging engagement with the healthcare
with the plan members,
with the members.
and or with the provider community.
Interesting.
They were very thankful that we facilitated this meeting, and they learned a lot, and they want to come back. There's a bunch of action items that we have that we got to follow up with. But one of the things I found most striking is that when I asked what their communication engagement strategies were, they each had slightly different iterations of the story, but for the most part, they don't really want to be in the business of even remotely being perceived as directing care, for example.
So what that tells me as a former economics graduate student is that the costs just don't hurt enough. There isn't actually enough pain on the part of, which I just have a hard time believing, but there isn't enough pain in the medium-sized employer market, or maybe even the small market, to realize that that they need to drive engagement with their employees.
So one of these employers, their budget's not $2 billion, but it's in the tens of millions, and I asked that question. What would it take? And she hadn't contemplated that. And would 10% be enough? What would your executive team say about you leaving 10% on the table? And her response to that essentially was 10% might be enough, but we have to provide choice. So we couldn't pursue a narrow network to the exclusion of having open access. So if we were to engage in that kind of a strategy, ACO-related strategy, it would have to be alongside an open access PPO option that move the needle vis-a-vis plan design or perhaps contribution strategy. So, I'm not sure that the mid-market employers in the community fully acknowledge their the opportunity that they have. And I think part of that is that they don't necessarily view their provision of healthcare in the employment setting as a leverage point through which they can gain some influence and help accelerate the evolution of healthcare in this community.
So I have, maybe I'll ask you this question, Jeff, and ask you to sort of reflect on a little bit, because I think you are the exception to the rule I will state here, which is often people will talk about healthcare illiteracy amongst Medicaid populations, consumers. I would argue there's tremendous health system illiteracy amongst the consumer world as well. I think that one of the reasons state reform is successful is because there is some level of health system illiteracy amongst healthcare professionals, meaning if you're successful in hospitals, it does not mean you know that much about county-led mental health. But I also think that employers are probably just as health system illiterate as Medicaid consumers. I mean, with exceptions of large purchasers, Alex's comments seem to reinforce that. What do you think about the system literacy? I mean, I think Boeing is a leader in that regard, but your peer organizations probably, they may not be as advanced and innovative as you. What do you think?
Yeah, I mean, I think there has been a recognition, exactly what Alex was saying, that the employers do have a role, and the systems welcome, I think, that direct conversation. And they're typically used to dealing with third-party insurers and negotiating with them and having relationships with them. And those guys will always have a key role in the system, at least for the foreseeable future. But they recognize the decision makers at the purchasers, and as Alex said, driving that commercial revenue for them. That's an extremely important revenue source for them. And we've found, even in our smaller markets where we don't have the leverage that we have here in Puget Sound, we're welcomed into the boardroom and they enjoy the back and forth. And I think, and we have seen some coalescence around some other employers and in certain activities we're doing where we go talk to the systems with other employers. And I think, again, those are well received, and I think, I don't want to say it's refreshing for them, but they do enjoy the direct dialogue. And there's stuff that Boeing can do to help, obviously, with the delivery of healthcare outside of the filter of working through our TPA or our insurance administrator. There's things we can do to help direct care and help give our employees treatment decision support tools, for example, that it's good to have the direct dialogue with the system to help fine tune those. So there's definitely a role there, and I think we'll see more of that. And I would encourage, even 2,000 employees, that's a substantial amount of revenue for a lot of systems. And I just encourage people to try to have those conversations with the hospital executive team, because they generally get it. And my experience in the systems we've been working with is the management understands that purchasers want more value for their money, and they need a platform to take this down to their, to their provider community within their organization and talk about the need for change on compensation. We can't continue to just compensate for production. Fee-for-service, unbridled fee-for-service has to go away or be modified on some level. This provides the healthcare management team somewhat of a platform to say, hey, the purchasers and our employer, our business community is asking for us to provide more value for the dollar. And so I think that having those direct engagements helps that dialogue and helps the executive team that the hospital systems go and have those conversations about compensation, for example, and bonuses and the like with their team.
So let me ask you this question, Jeff, and then Dorothy, you can answer the same one. I think that Boeing has been a recognized leader in community philanthropy in Puget Sound, and a recognized leader clearly in aerospace. And Rod Hochman, CEO of Providence, told me a bit ago that I asked him how his job was going. He said, or what is it like being a leader right now in this time of change? And he said, well, 15% of leadership is recruitment of great talent, 15% of leadership is strategy, and 70% of leadership is communication. And so within that framework, does Boeing feel like it has a responsibility to be a leader and communicate? I mean, you're here, so that's indicative of that. But do you feel like there's a role within the broader business community, including small businesses, for Boeing to lead out and communicate on this stuff? Or is that maybe just not the role that, I think most organizations would say, well, that's probably not our role to tell other businesses how to manage that, but what are your thoughts on that leadership question?
Yeah, I think for a large employer, I again feel like we have some obligation to try to be somewhat of a change agent or be out communicating about some type of health reform in general. So I do want our organization to be viewed as a leader in this area, and we, when it comes down to how in the face are we going to be with our employees is a different matter, and obviously employee choice is going to continue to be important to us. And there were some comments about how willing are employers to say to their employees, you got to do this. I think the employee communications is a separate issue, but I do think it's incumbent on some of the bigger commercial payers, whether it's an employer, whether it's a health insurer, when we feel like we have a path that will lead to improvement of delivery, that we do take a strong role in that. I think the health insurers have been doing various things for a while, some good, some okay. I think the community in general views it differently when an employer steps up and says, hey, we think this approach makes sense, this is what we're doing, and this is what we're driving. It's viewed in a different light, obviously, than an insurance company doing that. And I think we need both parties to be leaders in the delivery reform. So
Dorothy, same question, but with an add-on or a slightly different angle, because I think that the Healthcare Authority has demonstrated under the leadership of your period in office and with earning the CMMI grant prior, has demonstrated a real leadership in terms of communication and engagement with the broader community. But how do you see the Healthcare Authority, what is the role of the Healthcare Authority to fundamentally change the entire system? How do you think of that beyond public employees, beyond Medicaid, but how do you see your purchasing role within that non-traditional context?
Right. So that's a great question, and again, one that we've done a lot of thinking about, and I have very much appreciated being in this role that I'm in right now so that I can actually see at a much kind of broader level what is going on in the state of Washington. And a couple observations I would have, and it ties into what I think our role really can be and should be, is to help support everyone moving forward in the new value-based approaches for purchasing care. I think for smaller organizations, it's kind of hard to have the intellectual capital and the ability to really focus and create those products that we all want our employees or those that we purchase for to use. And so one of the things that we feel is really important for us to do, and we are doing, is to take, for example, the sample contract language, not the proprietary terms, but the concepts of our contracts that we have with our accountable care programs, and put those out for others to use, so that there's a way that people can not create from whole cloth themselves what's required to do that direct contracting. I think Jeff's right, it takes a lot of time and money to put that piece together. So as a public agency, we can then share that with others. So that's one thing. I was really struck at a Washington Roundtable meeting now probably almost 2 years ago with the governor, when the CEOs, big company CEOs, all said, our job is to run X, Y, or Z company. We trust the healthcare system to do what we do for our company in terms of their field of healthcare. We wouldn't ask a healthcare CEO to tell us how to run an energy company, for example. So it really struck me that what we can do then in our role is to say, okay, here's where the world needs to go. Here's where our delivery systems are. They're ready to partner and do a better job. They're ready to move away from a fee-for-service market into one where there's a focus on populations, total cost of care, improving health, et cetera. So we're putting together a conference in partnership with the Health Alliance, the Roundtable, King County, other purchasers that really want to help us. It's a purchasing conference, and actually just in several weeks. You can find out the details if you go to the Healthier Washington table. There's information. But I think our role is really to help push the concepts so that people don't all have to do this themselves. And most importantly, so that, again, if you're in the care delivery system, you start to have aligned sets of ideas, requirements, measures. The other thing that we can do, and actually we have been mandated to do by the legislature, is to have a common set of performance measures. So again, if everybody starts building those into their contracts, you've got a delivery system team out there, many of them obviously, that are going, okay, these are the measures, let's build around those. Yeah. So we can do those kind of things from our role, both from a health literacy, a strategy, and a support for others, that I think it's kind of a unique role, and we want to have that role as kind of purchasing support and, advocacy for the folks that live in the state of Washington.
So the healthcare system that the healthcare authority, Alex, rather, the healthcare services that the healthcare authority purchases from the healthcare system, those providers and the system is accountable to the healthcare authority because there's a contract. That system is accountable to Boeing because there's a contract and they can hold them to standards. In the commercial space, in the smaller space, to your point about the relative lack of engagement, not just of members, but I think of the healthcare system, there's no accountability I am perceiving, and I don't think this is stepping out. Small and medium employers are not holding the healthcare system accountable in the way that Dorothy and Jeff are. Isn't it then the role of the broker community to be the voice of accountability from the healthcare system? Or is that maybe not the role of brokers?
Well, I perceive it to be, at least in part, but I wouldn't say I'm the lone voice on this, but there aren't that many folks that would agree with me in our business, with the exception of perhaps some consultants who manage accounts, national account-sized accounts. But as David suggested a few minutes ago, the role of the consultant broker is evolving quickly from one that really was just more transaction-oriented to one that really has to be more consultative to add value. One of the things that we're focused on is to try to figure out ways to connect, well, first of all, help employers develop and implement employee benefit strategies that relate to health and productivity, for example. And wouldn't it be great if those strategies also connected with these organizations' business strategies, so that we can begin to measure the impact of the work that we do on things like health and productivity, maybe work comp costs, not just medical spend, claim costs, But the holy grail for me would be to be able to tie the things that we do to measuring the impact on net operating income of businesses. Because I'm one of a few execs that run a $50 million business in the Northwest, and very few things are as important to me as the health and productivity of my workforce. The healthier and more productive they are, the better job I can do, the better job we do for our clients, the more we thrive, and that's true for all businesses. And I think our focus, the consulting brokerage community, needs to be on things. The trick is to be able to measure them, to have the internal resources to do that, to have the motivation to do that, rather than just deal with a health plan as if it's a series of one-off annual events. It takes resources to do the things that I'm talking about, and those resources, when deployed, impact margins in the short term. So there are business decisions to be made, and I just think those business decisions are in the community's best interest, and I think it's imperative if we're going to, as brokers and consultants, contribute to this community to the extent that we can, to take that responsibility seriously.
So, David, I'll give you the last word as we're getting short on time. Prognosis for the role of employers moving forward within the context of the 1993 federal health reform initiative that was opposed generally by business, and the 2009-2010 Affordable Care Act health reform initiative that was generally supported by some of the bigger players in business. And that was perceived as a watershed difference that allowed the ACA to get over the hump politically, regardless of the policy that it helped politically. Are we going to see, we've talked about how there's wide variation in engagement on this issue, but politically, we have not solved healthcare yet in terms of fixing it. Will business at either large or medium or small levels become more engaged in the next 10 years in a way that would allow for continued policymaking to continue to reform healthcare? Or have we passed that inflection point where we're in a period of stasis for a while?
Well, I think we're at the beginning, and employers have gone from voluntary participants to mandated, and individuals have gone from voluntary to mandated, and yet the bigger picture is not sustainable for healthcare, the economics, and so there's going to have to be engagement. It's going to go from sitting back and waiting to see what happens to being forced, really, to be engaged. And so I think that's going to be the case for employers and for employees, as well as individuals who have to purchase, health care. We're going to have to come together and make the system more sustainable. Yeah. And the economics of the system have to be more sustainable.
Let's give them a round of applause. Thank you, David Snodgrass from Healthcare Management Administrators, Alex Rule from Arthur J. Gallagher, Dorothy Teeter from the Healthcare Authority, Jeff White from Boeing. Thank you.